Well, I'm Sean Devine. I'll take the lead on this, talking about the non-arthritic hip. Okay, what I'll do is do about the first half of this and then hand it over to my associate, Dr. Woods. When we think about hip pain, in some ways we're preaching to the Pope, because the primary care physicians, the therapists, they see an awful lot of hip pain, and we have to remember it's not just an orthopedic bone issue. There's a lot of layers. And so a lot of papers will always take us back to medical school and say, take that layered approach, you know, look big picture before you get too focused little picture. I'm a little picture sort of part of the puzzle, and that's why I make the point about preaching to the Pope. Don't forget all those other issues. I won't be speaking about your intra-abdominal retroperitoneal pain sources. Back pain is obviously a huge element of hip pain. I had a guy in today that probably has spinal stenosis, got a lot of buttock pain, which he felt was his hip replacement. You know about the straight leg raise, you know about more of a posterior hip pain complex. Again, you're better at that than, or at least as good as I am, so I won't waste time talking about that. I will spend a little time talking about pubalgia, athletic pubalgia. We'll spend a little time talking about trochanteric bursitis, and then I'll talk about the intra-articular sources of hip pain that have kind of come into our horizon in the last 20 years. Hip pain, when I started in town 24 years ago, was pretty simple. You had arthritis, you had bursitis, or you had a groin pull, you know. If you didn't fit those three cubby holes, you know, we didn't have much to offer you. Things have really expanded in the last 20 years, so I think we're seeing a lot more interest in it. Pubalgia, or sometimes athletic pubalgia, is a controversial area. It's difficult to characterize pubalgia for both specialist and generalist because it doesn't follow absolutes. There isn't an absolute patient history. There isn't an absolute physical finding. There aren't absolute diagnostic tests. And again, you have to look globally. I see a lot of it taking care of athletes. You can have sources of pain all around that anterior pelvis that may present as athletic pubalgia. These are some of the most common things you'll see. I'm not going to talk about the adolescent avulsion injuries, the most common being the hamstring avulsion injury. That's about 50% of our 12, 13, 14-year-old avulsion injuries. The anterior inferior iliac spine is the second most common, and the ASIS, the superior, is the third most common. Usually treated non-operatively unless it's displaced, say, more than probably 3 centimeters to meet most people's criteria. This is sort of the lay of the land in terms of athletic pubalgia. These are the areas you're looking at. I got a call from Frank Mazzoni just last week on somebody with very refractory osteitis pubis, you know, a elite level runner that's been symptomatic for over a year. So it's out there. Sports hernia, there's controversy here, and if you talk to the Hayashis, Steve Tiddick, any of the general surgeons, they'll be quick to kind of review for you the controversy. The difficulty is that we don't have one defined anatomic structure that's the cause. Typically, you've got a dilated, somewhat physiologically widened superficial inguinal wing and a tender posterior inguinal canal. Any number of structures can be involved in producing this weakness of the back of the inguinal canal. It tends to be an injury almost exclusively of males, and it tends to be twisting sports. It was called, you know, hockey players' hernia. We see it maybe 5 to 8% of soccer, elite level soccer players may have it. And you'll hear a common theme of the talk. It can take a long time to really establish the diagnosis. The treatment, same old treatment. You know, you're going to rest it. You're going to use anti-inflammatories, use therapy for your core strengthening and flexibility. The problem with this is that there are failures. I mean, this is the groin pain that doesn't get better, very specific to activity-related pain. The athlete does well up to 70, 80%, but then as they really try to get back to those really ballistic loads, torsional loads, it just isn't going away. And that's when you get them in with general surgery. There are some MRI protocols. Fred and I know have talked about those that may be better about picking up the areas. You know, we'll be looking at the adductor tendons, we'll be looking at the abdominals, we'll be looking in the area of the back of the abdominal wall, transversalis fascia, and then it goes to the general surgeon to see if he's got enough based on history, exam, and diagnostic studies to take the next laparoscopic step. As controversial as I'm not going to bore you with the literature. There are study after study after study showing that the entity is real and that surgical treatment can be very successful in these unfortunate people. So that's kind of the quick little review on where we are with sports hernia. I don't know that it's as controversial as it was 5 years ago. There's been enough clinical studies to show that it's real and it does benefit from intervention when you have those refractory cases. Trochanteric bursitis. Talk about a big topic. I mean, who hasn't seen it and had it involve them or a family member? You know, almost everyone gets it at some point. And trochanteric bursitis, we sort of have a standard presentation. It's the lateral hip pain. They're tender right over the greater trochanter. The standard treatment is the therapy referral, the avoiding the activities that seem to bring it on, the stepping type loads, the icing, doing that IT band stretching, and cortisone injection. We've all had the patient that just isn't getting better. They're not turning around. They've done everything. They're really suffering. They want to get their 4th cortisone shot. Now what do? You know, does anyone here want to keep giving these people cortisone shots every, 3 to 4 months? Dan, what do you do? What would you think about?
Well, one of the things I think about is a possible gluteus medius tear, the so-called rotator cuff. So I might study that patient. It's been that long.
Okay. And that's exactly where we're going right now. It's pretty new in everybody's radar, but we're getting these studies and we're finding it out that, wow, some of these patients had an abductor mechanism compromise. You know, look for that patient with a Trendelenburg gait. Look for that patient that may have had something of an event where it's a more precipitous onset that may have been a abductor overload. Just a quick review, anatomy. I got to bore you with something. These hip abductors are huge muscles. They're very important. This is a side view of the hip showing where the various muscles insert onto the hip. This is where the tear occurs. Now, the A is on the front of the, oops, probably broke it. This is obviously the front of the pelvis here, the back of the pelvis with the sacrum on this side. And this is right where that tear occurs, that tendon defect in that gluteus medius. And here's an MRI. Fred, I don't know if this is from you or not. It may well be. And that's showing the defect. This is one of my partner's cases. I can circle it right there where the abductor mechanism, the medius, is torn. And this is a blow-up of that area showing the separation tear. I think this is one of your studies. And this is essentially what we do surgically is you just go in and split the tensor, get down to it, and then do a repair of that area. And pretty satisfying. The patients that have the entity really see dramatic improvement. So fairly new in everybody's radar, something you want to know for that refractory recalcitrant case of trochanteric bursitis. Let's talk quickly about intra-articular pain. There's a lot of patient-driven momentum to, doc, I've got a sore hip, I want an MRI. They're thinking, I've got a labral tear. They've heard about this in pictures with their shoulders. They've heard about it in their, friends that have had meniscus tears in the knee. And it's taken on a lot of momentum recently. Again, remember that most injuries in athletes aren't labral tears. There's soft tissue injuries around the hips. Start extra-articular first before you get too focused on intra-articular. The patient may be a little over-focused intra-articular. Again, this is a sort of an occult injury that tends to present very slowly and non-diagnostically. It's the patient with typically more anterior groin pain that isn't getting better. It's a little lower than your inguinal canal. It's a little more lateral. It can be posterior, okay? We talk about, and I'll get to it later, sort of the classic C sign. The patient's kind of going, it kind of hurts in there, doc. They wrap that hand right around the hip, trying to get inside. Overwhelmingly, these are overuse injuries where the patient, it just slowly gets worse and worse. And the overwhelming cause for these is what we call femoral acetabular impingement, where you're getting some contact, pathologic contact between the femoral head, neck, and the acetabular rim. Okay. We refer to that as FAI. We like to make these long words shorter. Two types. There's the pincer type, more common in females, and there's the cam type, a little more common in males. The cam is on the femur side, the pincer is on the socket side. This is the pincer picture, and it's not as easy to see as I would like it to be, but what the red arrow is showing is the posterolateral rim of the socket itself. That's the offending agent. This patient has overcoverage. And when they bring that hip up into flexion, that prominent lateral rim is bumping into the femur, and the labrum is getting torn because it's caught between. Okay? Not as common, but we will see it. When you see the acetabulum with some extra ossicles right there at the edge, that's an ossifying labrum. That's almost pathognomonic for overload. Okay. This is the more common thing, and it's almost the exclusive presenting problem in my practice, is a cam lesion, more in the adults. And what you're getting is you've literally got a bump on the hip. But it's this area where instead of having the normal contour of the neck into the head, you've got a bony prominence. And what that does is it rides up under the labrum and causes a shear injury, so that the labrum and the cartilage that it blends into separate. So this is actually not a direct compression injury, but a shear injury. By far the most common mechanism presenting in my practice, Dan's practice, is cam lesions. And typically you're active, young to middle-aged patient, months if not years delaying the diagnosis. Anterior groin pain is the most common presenting complaint, although lateral and posterior pain can be present, making the diagnosis more difficult. This is activity-associated pain, but a classic complaint is, doc, it hurts to sit. When I have to go on a long car ride, I'm miserable. Pain getting up from a seated position. On examination, we do have some tests that can help. I talked about the C sign earlier. When you do a simple log roll of the leg in and out, and it produces pain, that takes you into the joint. That's an intra-articular source. The internal impingement test, the anterior impingement test, we use that, everybody uses that, and that really is, it's not diagnostic, but it's helpful. It's sensitive, but not specific. The Faber test is the external rotation, flexion, abduction, external rotation. People know it for loading the SI joints, but it also seems to irritate that labrum, and that can be positive as well. And sometimes it isn't so much pain as it's just tightness. They can't, they can't get down to within 4 centimeters of the exam table with that figure 4 position, and they're really asymmetric. Start thinking about that tight anterior capsule. Think that it may be an intra-articular source. This is the anterior impingement test. This is a take-home. You flex the hip up, and then you're going to adduct it and internally rotate it, just like that. And that is probably one of our most diagnostic tests. There's a lot of names and we get tired of eponyms, but you can also flex the hip and rotate it from internal to external, from slightly adducted to abducted with a compression load. That can also be very symptomatic with patients with labral tearing. X-rays, I'll spend just a minute. Over coverage, the pincer lesion, you may have an increased center edge angle, so that this angle may be increased, that you've got over coverage. The other thing you'll see is that the acetabulum is retroverted. The socket doesn't antivert, normally the 15-ish degrees forward, but it's neutral to retroverted. And we talk about this crossover sign. You'll get that report from Fred and other radiologists talking about, we've got a little crossover here where the anterior rim is in front of the posterior rim, suggesting that there is a retroverted acetabulum. You know, we talk about it a lot. I don't know that we see it that often. The done lateral is an important X-ray, and that's one everyone needs to kind of learn. It's not that full frog lateral, you're trying to see the anterolateral part of the neck. That's where these bumps occur, on the anterior lateral kind of quadrant. And so by half rotating the hip, what we call a done lateral, you'll pick that up, and this X-ray shows that really well. And the alpha angle is something that Fred will report, and it is something that I think is helpful. I really do. You've normally got a ball on top of the neck, and what happens with the alpha angle is that's where the sphericity of the ball is lost, where it hits the neck and it falls out of sphericity. And that's how that's defined. And normally less than 50 or 55 degrees. These sort of pistol grip hips, the old slip capital femoral epiphysis, the classic pistol grip hip, they've got a cam lesion by definition. We're not quite there, but it may not be outside of the realm of possibility that we may be looking at almost proactively treating these people in the future. As I said, we're not there yet, but that does predispose this patient to more mechanical impingement, which may be a precursor of arthritis. If you're going to get an MRI, please get a injection study, because we can get more information. Please try to get the highest accuracy, highest energy machine you can get. Dr. Casper and I in our practice really do see a difference between the 1.5s and the 3s. We won't push people to get 3 Tesla MRIs routinely, but on our hips we really think it matters. And I get an awful lot of hips that have had a non-dye 1.5 study and it has to be repeated. And then the patient's frustrated, everyone's frustrated. Fred and crew will add contrast. We'll add a little local anesthetic, and we'll add a little steroid. And the anesthetic, and you can measure these alpha angles with your laterals or on the MRI. You can see this large cam lesion here, and this is coming out of sphericity at 79 degrees, so he's going to qualify as a cam. The intra-articular anesthetic, one study had a 91% sensitivity for defining intra-articular source. So I tell my patients that I want them to do a and this is just that, it's an MRI with the intra-articular dye, with the cam, and here's a MRI picture showing a labral tear where the labrum is separated off the edge of the acetabular rim. The one thing that I kind of skipped over quickly, and I think it's a take-home point, is I always ask my patients to do a clinical test when we get an MRI. And so when I send him over to Fred and he's injecting the hip with a 2 or 3 hour anesthetic, I ask them to go do something that hurts. Don't go home and take a nap. Go do something that will reproducibly make your hip hurt, and compare how it feels in that 2 or 3 hour interval versus how it felt yesterday or 3 days ago when you did that same activity. Because if there's a dramatic improvement in the pain, that's really important information. Okay? That's something that we'll use in our kind of litmus test for, is this patient a candidate to consider the next step arthroscopy or not? How do they respond to that injection? We'll put a little cortisone in there as well, and that'll be a delayed improvement phase. Okay, as Fred knows, as I know, Be a little aware of the posterior labral tear. There's a normal anatomic sulcus back there that can fool the unwary. And so we're very apprehensive about the call of a posterior labral tear. I just want the primary contact people to also, be aware as well. Labral treatment, hip arthroscopy. We thought the guys that started this in the early 90s were just nutcases. I mean, I did, most of us did. Just looking for a new, thing to poke that scope into. They were right, I was wrong. There is a lot to be gained here, but it is a deep structure and everything is more complicated getting in there. You're punching through more stuff. Everything has to be bigger, longer. These are just a couple pictures to give people an idea of what we're looking at. We have these table extensions. We've got this big padded groin post that we're going to pull against. We carefully pad the feet. We use positioning so that we can kind of lever that hip open. We're essentially dislocating your hip under anesthesia. The thing that took Bo Derek out, not Bo Derek, Bo Jackson. Take Bo Derek out. We're essentially doing that in the operating room. These are our sort of standard operative portals that we'll work through. 95% of the time we're just using those two little holes. And this is what it looks like inside. On the right hip, that's our first pass with the needle, and then we'll put dilators over that. We'll put a guide wire through that, then we'll put dilators, and then we can put on the left is a scope cannula. Now we can start putting our scope in and passing our instruments. And I'll just show you a couple of pictures. Here's a labral tear, and this is where the labrum is torn and it's delaminating right onto the cartilage surface. That whole cartilage surface is at risk just to peel off as that thing keeps getting caught. I mean, the pathology can be dramatic. Okay, let me go to the next one. This is just another, I think I hit it again, it'll run. This is the labrum here on the that the probe is in. 80% of the surface on the left is the normal cartilage. The labrum blends right into the cartilage. That's the extent of the labral tearing. That whole thing is just shredding and starting to delaminate. And now we'll get out to the outer edge. This is the normal outer edge of the labrum here. And so that gives you an idea. That's the outer edge. And what we'll often have to do is release the outer edge to be able to do the work we need to do on the inside. Now this is a picture of us putting in our anchors to repair the labrum. I'm running a couple of minutes over, so I'm just going to stop here in a second. This is drilling in one of our anchors, and we'll just show how we're able to put our sutures up with these anchors into the acetabular rim. We took down a pincer lesion there. Now we're going to reattach the labrum back up where it belongs, having done the debridement, having stopped that peel-off lesion of the underlying cartilage. And so we're just going through the labrum, around the labrum. Now we actually go through it twice as opposed to going around it. This is a slightly older video, and that's tying it up. And then the final step can be the cam lesion, and that was a key point that I kind of passed over earlier. You've got to identify, why is this patient here? What's the cause? And if you're not effectively treating that bony ossicle, that cam, this is going to fail. And so we'll spend an hour, 45 minutes working on that cam, getting it down, getting it nice and smooth. So that this is actually work on that head-neck junction, removing that bony prominence. Results, our pioneering experts are reporting 80 to 90% good and excellent results. Patient selection can't be overemphasized. This is not a predictable treatment for arthritis, and in the patient that's got arthritis, the tough love is no, it's not going to work. It could even make you a little worse. I'm going to turn it over to my partner, Dr. Woods.
Sean, when you're reattaching the labrum, do you need to make both surfaces bleed? I didn't see any bleeding when you were pulling those together. What holds it together without?
We'll work very hard on the edge of the acetabulum to make sure we're down to nice and bleeding bone. That'll be the source of the blood supply. That is the source. You won't see bleeding coming from the labrum. It's relatively dysvascular.
Okay.
Yeah.
So just bleeding in the bone itself?
The bone edge, yeah. And that's what we're pulling it up against. Yeah.
Good job, Sean.
Thank
So Sean's talked about the soft tissue problems about the hip. I'm going to take a different tact and start talking a little bit about more of the intra-articular arthritic hip. And if we have some time, actually talk a little bit about some newer techniques and fracture management as well. So how common is hip pain? There was a study that was done in 2002 where they talked and interviewed over 6,500 patients. These were patients over the age of 60. And the question they asked was, how many times in the last 6 weeks have you had hip pain? And 14.3% of these patients reported significant hip pain, not just once or twice, but daily for the previous 6 weeks. So hip pain is a very common problem. So when a patient shows up in our offices or your office and says, "Doc, I've got this pain in my hip," one of the first clues as to getting your diagnosis is actually talking with the patient about where that hip pain is and looking at the location of the pain. So, is the pain the lateral side of the hip? Is it to the front of the groin, posterior hip, or is this referred pain? And we'll talk a little bit about that. Lateral hip pain, there are two types. The first is aggravated by direct pressure. That's the trochanteric bursitis, people laying on a hip that come in saying, "Hey, I can't sleep at night, my hip hurts." And as Sean went through very well, there's also that hip abductor tendon tear that we've become aware of now. The second is hip pain on the lateral side of the hip associated with paresthesias and hyposthesias. The lateral femoral cutaneous nerve can be entrapped as it comes out of the pelvis or can be damaged. Larger individuals with a tight belt can start getting numbness to the front of their thigh. That's myalgia paresthetica. And we can also see lateral hip pain caused by a lumbar radiculopathy. Now, anterior hip pain or groin pain is really the classic location for a problem that involves primarily the hip joint, be it the arthritic hip or, as Sean was saying, a patient with a labral tear. There were two doctors, both with the last name Buchan, one from England, one from Scotland, that interviewed patients that were set up for hip replacement surgery or spinal stenosis surgery. On the hip patients, 80% of them, or over 70% anyway, of both those studies, had pain to the groin or to the front of their hips. What's the differential diagnosis of anterior hip or groin pain? These include things like osteonecrosis, which I'm not going to spend time on, labral pathology that Sean so well covered, lumbar spine disease. People that come in, how many times have you seen a patient come in and say, "Doc, I've got a bad hip," and they're pointing back here. And then tumors adjacent to the hip joint can also cause pain to the groin. Now, the least common pattern for an intra-articular hip problem is the posterior hip pain. The differential diagnosis to posterior hip pain is sacroiliac joint disease, lumbar radiculopathy. We see that a lot. Patients coming in with, quote, hip pain that have either spinal stenosis or a disc problem. And then, of course, herpes zoster can cause pain in that area. Now let's move on to some of the latest advances in the care of the arthritic hip. This is a picture I show a lot of my patients in the office just to explain what arthritis is to them, showing the loss of cartilage there, the development of spurs, and I use this also to show them how we take care of this problem. Now, what are some of the diagnostic clues that a patient has hip arthritis? You guys know these better than I do, I'm sure, but groin pain we talked about, 70% have anterior pain of the hip or groin pain. The C sign that Sean talked about, you can see this patient up on the screen there is sort of a two-handed C sign. They've got their hand on the front of the hip as well as in the back of the hip. But the classic is saying, "Doc, I've got pain right here," as Sean was talking about. And then on examination, these patients have pain on internal rotation. That same test that Sean was showing, even without abduction, when you go to try and check their range of motion internally, they have pain. That hurts. And their internal rotation is typically less than 15 degrees. Their hip flexion, less than 115 degrees. I was riding my bike with some buddies one morning, happened to be riding behind one of my friends. And I looked up and I saw his foot. He was, sort of riding like this. One of his feet was externally rotated. That's the other thing that can happen. In fact, I asked him at our next stop, I said, "Hey, Donnie, you got a problem with your hip?" He goes, yeah, this has been bugging me for about 6 months. Well, got an x-ray, and sure enough, he had bone-on-bone changes to his hip, and 6 months later has a new hip. But that external rotation gait, because they can't get that foot in. Unusual presentations of the hip. How many times have you seen a patient come in and they are complaining of knee pain? Said, Doc, I've got this terrible knee pain. I've had patients that have come in that have actually had an arthroscopy of the knee and they found nothing. Well, this is mediated by a couple of the nerves around the hip. The obturator nerve and the saphenous nerve supply sensation to the anterior and medial side of the knee. And when those nerves, the way I explain it to patients is that there's sort of a short circuit that occurs. As those nerves come up, they're normal. They meet the hip nerves, or it may be that the femoral nerve comes right over the anterior part of the capsule, and there's sort of a problem with the transmission. And it feels like it's happening down here, but it's really up here. Try talking a patient that comes in with severe knee pain into having a hip, total joint. The way we do that is just the way Sean had mentioned, by sending him to Fred, saying, hey, let's do an injection in that hip. We put in some Marcaine, put in some Depomedrol. Voila, their knee pain goes away, and I've convinced them that your problem's the hip. We see that not infrequently. This next slide just shows the distribution of some of the sensory nerves. This is a male thigh on the anterior aspect right. You can see that the obturator nerve supplies the medial aspect of the knee, the front of the knee, and actually down into the shin. I mean, I used to tell patients, you've got that came in with calf pain, saying, I think it's my hip, or I think it's my knee. Hip pain actually, in 47% of cases, in one study that was done, did result in, or hip problems in a pain down to the shin or pain into the calf. Now, what about diagnostic imaging? The gold standard for diagnosing osteoarthritis of the hip is an AP of the pelvis and a lateral of the hip. MRIs are not necessary for that diagnosis. Now, if we've done all those studies, and yes, we'll get a contrast MRI, to look for other pathology. But just to kind of illustrate that, this is a patient that came in my office last week, a 70-year-old with buttock pain, groin pain, and knee pain. And this was her x-ray. This was taken back in January of 2013. And just sort of going in a little further and a little closer on that x-ray, you can see the classic findings. There's central joint space narrowing. There are spurs out here, some spurs down to the lower part of the neck. The next x-ray is the same date. This is the lateral view. So you see on the posterior aspect of the head and the anterior aspect, this this pinch lesion that Sean was talking about, and joint space loss. So that is, end-stage osteoarthritis by radiographs. So once again, January. So the patient came in last week, and if you will, it's a coronal image, but it's an AP of the hip. And I don't know if you can see it, but there's just absolutely no joint space left here. You can see that a big spur out in this area here. You've actually got some head collapse there. Now, this is a picture of an x-ray I took of her hip this last week, and you can see that big spur out here. The joint space is completely gone. And what this illustrates, two things. One, you can see a lot of changes in the hip in a year and a half. That is a long time. We can see changes like that in much less than a year and a half. But the other thing it illustrates is that, with a $70 AP of the pelvis, you could make this diagnosis and save the patient $600. So start with an x-ray. I'm not going to go into the detail about conservative treatment of osteoarthritis other than to make 2 points. One is that Medicare is forcing us, because of RAC audits, to send our patients for physical therapy. And I think physical therapy can help some of these patients, but by and large it does not. So the other one is just that intra-articular steroid injection we talked about. Unlike knee arthritis or some of the other larger joints, I found in my practice, I don't know about you, Sean, but cortisone injections in a hip may last 3 weeks. They don't last long. So they're really not a great treatment option. I use them for diagnosis, but I don't use them for treatment. Okay, and then let's go on and move to the operative treatment of OA of the hip, there are really three different approaches that have been used over the years. You see the posterior lateral approach, which is the most common. I'll talk about that. An anterior lateral approach, and then finally the direct anterior approach. This is positioning for a posterior lateral approach, which is the way that all of us learned how to do hip replacements. And it's a very good procedure. 75 to 80% of hip replacements in this country are still done through a posterior lateral approach. The patient's positioned with a hip positioning device. We make an incision, of the posterior lateral aspect of the hip, and then go in and replace that hip, and I'll show you that. So, total hip complications are listed up here. Hip dislocations, a very common one in the past, leg length inequality, blood loss, deep venous thrombosis, infection fractures, and polyethylene wear, which can lead to loosening of the components. I want to concentrate just on 3 or 4 of those as to some of the advances that are being made in replacement surgery. This is a picture of a hip, a right hip. You can see this is the head up here down to the feet down here. And in a posterior lateral approach, what we do is split the gluteus maximus muscle, which here has been reflected, and take down those smaller muscles called the short external rotators. Open the capsule, replace the hip, and then try and get those back, attached to the hip. But that's what accounts for the hip precautions that we often see, posterior hip precautions. That is, not crossing your legs, not bending over 90 degrees, not sitting in low stools, etc. Because those structures have to heal back there to give you a tight hip.
How well does muscle heal to muscle?
Well, you're actually taking the tendons and trying to fasten them back to bone. And I haven't seen any studies that actually looked at how much that stuff's back there, but it does scar back in. But do the muscles function? I don't think so. I think it's just a matter of getting a bump back there. So the causes of hip dislocation, leg length inequality. If you put a hip in too short, it's going to not tension the ligaments and the muscles. Cup malposition, getting the cup too vertical, can lead to dislocation. Stem malposition, instead of a normal 15, maybe over anteverting it or retroverting it, can lead to dislocations either anterior or posterior. Uncorrected offset, the hip muscles have to be tensed, to have that muscle function to help hold that hip in. And then we see hyperlax individuals and patients with muscle disruptions. This is a patient that I've taken care of. This is an example of global laxity. This guy's got hyperextension of his knee of about 20 degrees. Now, I don't care what approach you use, this is going to be a difficult patient. In fact, this guy is one of my anterior hips, the one guy that dislocated and had a recurrence of his dislocation. He was out 4 weeks on the golf course, doing a full swing, and popped it out. Leg length inequality, that's one we want to talk about. When we replace hips, we make a femoral neck cut of varying lengths, and then we can also change the length of the leg by making that cut too long or too short. Then when we have the stem in there, either the neck head piece, you can have that off, and a patient will end up with a leg length inequality that they're not too happy about. With the posterior approach, there's numerous ways to try and make sure that you get these right. This is a positioning device that positions the patient fairly rigidly on the table. Then you can see my hand here. This is how I have done it with posterior approaches, is line up the knees before surgery, before we prep and drape, and then during surgery after I've got the trials in there, see if I can match that up. If I need to lengthen them, make it a little bit longer. If I need to shorten them, which is rarely the case, a little shorter. So this has prompted looking for different ways to do hip replacements to try and mitigate some of these complications that we've seen. And this is the direct anterior approach. And this approach, this is a patient's buttock here, head up here, toes down there. You can see the tensor fasciolatum muscle and the sartorius. Make an incision of about 4 inches a little less than 4 inches. Go between these two muscles. We don't have to cut any muscle, and we're right down on the hip capsule. Open the hip capsule, replace the hip, and then close the capsule. Let those muscles just come back together and close up the subcutaneous tissue and the skin. And we're able to access that hip and do that through that small incision and by using this table. This is called the HANA table, and it serves two purposes. One, these two pieces here are sterilized, and so once we've got the patient draped, we'll put this table bracket on, and then once we're into the hip, I've replaced the socket already, we can slide this little hook under the femur, and using this hydraulic or electric jack here, actually lift the femur into the wound, so that we can access the canal. Now, this is an X-ray showing cup malposition. I can just tell you that this cup is too vertical. This patient didn't have dislocation problems, but this also puts a lot of extra stress right on the plastic here. So I've seen a number of patients, in fact, just replace the plastic on a 15-year-old hip that had worn out that plastic because of a vertical position. Now, with the anterior approach, the direct anterior approach, we can, let me get this going. We take x-rays during surgery. That's the other thing the table allows us to do, is it's a radiolucent table. And here, the technician is taking a piece of clear x-ray material overlying the image that we take. This cup is the final cup. This is a trial stem. And he's outlining all the bony landmarks on that patient's pelvis. Now what we'll do is take that, flip it over to the opposite hip, and we can line it up here and just check your leg length. When this matches, these two match, you've got a hip that's perfectly lengthened. Now what about, what's the literature saying about the anterior approach? There are two articles I want to just briefly highlight. The first one is a prospective study taking a look at a direct anterior approach versus the posterior lateral approach. And in this study, the endpoint was how well these patients walked, or when they walked normally and when they could do stairs normally. When I say walking normally, I mean an unlimited distance. And so they looked at both the mediates, in the first couple of days, they looked at those parameters. Then they looked at 6 weeks, 3 months, 6 months, and 12 months. Well, immediately after surgery, the analog pain scales were much less for the anterior approach. Patients used less pain medication. Walking distances on post-op day were better than they were on the posterior approaches. And more patients were climbing stairs and walking in an unlimited fashion at 6 weeks. And still at 3 months, there were higher functional scales in those patients. Whereas though, at 6 and 12 months, they were the same as the posterior lateral approach. So posterior lateral is still a very good way to do hip replacements. But the studies are showing that the anterior approach does accelerate rehab. The second study is 150 patients. This single surgeon took 150 of his mini posterior approaches. The second 50 cases were his learning curve on the anterior approach. And his third set were, the next 50 patients that he did after he'd gotten the technique down. And what he showed is that there was a significant reduction in the hospital length of stays. For the initial 50 of the anterior, it was 2.9 days. It dropped down to 2.7 after he'd done 50. And then that's in comparison to 3.9 days for the posterior approach. Discharge to home was more likely with the anterior approach than going to, say, a rehab facility, 80 and 84 versus 56. And there was significantly less use of assisted devices and narcotics at 6 weeks, and then pain was significantly lower.
And what about infection, dislocation rate, DVT, other complications in the short term?
In the short term, I'll get to those, Fred. But in answer to your question, infection, I haven't had a single infection in mine. I don't have any studies that show what the infection rate is. The dislocation rate in this guy's study is the same, 0. Neither one of these had it. I think the previous study, I think there was one dislocation in the posterior group that was recurrent. So the dislocation rate typically on a total hip is quoted as 3 to 5%.
Historic literature, yeah.
Historically. Now, but that's old literature as well. With anterior, it's less than 1%. DVTs, I'll get to that one in just a second here. But my experience has been that most of these patients are on oral pain medication by post-op day 1. They're ambulating anywhere from 150 to 300 feet by post-op day 1, some of them up to 1,200 feet. A higher number are going home versus TCF, and fewer of the patients are needing in-home health PT. And then more are walking normally. It's not uncommon to see a patient come into my office at 3 weeks, walking with a normal speed, normal gait, no limp. You've probably seen the same thing, Sean. Sean's been doing anterior approaches as well. I want to just briefly talk about some of the other things that we're doing with total joints. Blood loss is the next one I'll talk about. For the last 2.5 years, I've been using Tranexamic Acid. This is an antifibrinolytic that functions to decrease the breakdown of the clot. And as a result, this one study that I just showed you, or kind of flashed by quickly, without Tranexamic Acid, their transfusion rate was 6.5%. With Tranexamic Acid, the transfusion rate was down to 0.3%. And my experience in using it the last 2 years or so with both total knees and total hips, I've seen 3 transfusions, and that's a significant decrease from what I normally would have seen. One of those patients just had an artery in the middle of the femoral canal. It was just pumping like crazy and lost a lot of blood until we got the prosthesis in. So
blood loss all occurs during the operative procedure?
No, there's some blood loss that occurs after, surgery as well. But typically, this is a transfusion rate for entire hospitalization.
Has anyone looked at the infection rate tied to it? Because transfusion rate is directly tied to rate of infections.
I don't know if there's a study. I'm sure they've looked at that, but I don't know of a study. Fred, you were asking about deep venous thrombosis. One of the things that we're seeing in our orthopedic literature is that there's a move away from Coumadin, from Lovenox, and some of those drugs to just using aspirin. I know that the cardiac thoracic or cardiothoracic literature and recommendations don't jive with that, but in big studies, we're talking thousands of patients in the orthopedic literature, patients with knee and hip replacements are being treated with aspirin unless they have high risk, strong family history or previous DVT and so forth. So compression sleeves, early ambulation that we're seeing with these patients now. 20 years ago, 30 years ago, when I started practice, patients were in the hospital with a total hip for 5-7 days. Now they're gone. So I'd say 1/3 of my patients go home next day with an anterior. And we're kind of getting a little tight on time, but I just wanted to go over just a couple things as it relates to some of the changes with femoral neck fractures. Now, there's no question as to what we do with a non-displaced femoral neck fracture. That's percutaneous screws up the neck into the head. I typically keep these patients toe touch, weight bearing. Sean, what do you do?
Or full weight bearing.
You go full, yeah. I'm not that brave, I guess. Displaced femoral neck fractures, that's some controversy. You can see a displaced neck fracture here. In a couple of studies, I'll just go over real quickly. In a Scottish study, they randomized in 2006 patients that had either internal fixation, a hemiarthroplasty, or a total. There are no differences in the mortality rate of those patients, but the rate of secondary surgery was a lot higher with the fixation patients. These are patients that had a reduction of their hip and either screws or screw and side plate. And that's versus 5% with the hemis and 9% with the totals. And the fixation group had much worse functional scores. Another study, ORF versus arthroplasty. This was a prospective randomized study. 450 patients at 2 years. Their failure rate with the ORF was 43%. With the arthroplasty, just 6%. Impaired walking was 36% at 2 years. Arthroplasty 25%. Understand these are older patients. Severe pain 6% versus 1.5%. And so really what both these studies have shown is that the cost, you think, well, a total hip is a lot more costly to do than, say, a fixation. But that's not true when you take into consideration the failure rates. This is a hemiarthroplasty for displaced femoral neck fracture. The next question that comes up is, do you do a hemiarthroplasty for these patients or total hip? This is another study. They did 120 patients who were over 80 years old. They randomized them into either a total or hemi. And they found that the total hip arthroplasty, the surgery was longer, 102 minutes versus 78 for a hemi. Blood loss was a little higher, not too bad, 140 cc's more on average. No differences in the complication or morbidity, but the hip functional scores were much, much better in patients with a total hip arthroplasty. And their health quality of life measures were also improved. So quickly, this is a 72-year-old retired construction worker that was knocked over by a tractor. So this is a very active guy. He was out in his field and got knocked over and had a displaced femoral neck fracture. This is a CT scan. On the AP, it didn't look like this guy was displaced, but and we don't usually get CTs on every hip fracture, but you can see that his neck is, quite displaced there. So this was one of my early patients. I took him to surgery, did a total hip arthroplasty. This is him at 3 weeks in his first post-op visit. Went to go put his shoes back on, and I caught him leaning over. This is not hip precautions. This guy then, I had him just walk down our ramp there. This is at 3 weeks post-op, not using any cane. And you can see that he's got a pretty normal gait. I guess we have time for some questions. Sean?
Tends to be the mechanism of injury for a gluteus medius tear that might be unique to that tear, or just depends? Okay.
Yeah, I think if you've got a history of an injury, a fall, a misstep, something like that, where you may get a tensile overload, that raises the question mark. If you've got a refractory case, if you've got weakness, if you've got pain with more resisted abduction, with the simple bursitis, you're not going to get as much activity load associated pain.
Okay.
Yeah.
Any other questions?
What brought me over to the anterior approach that Dan was one of the leads on here locally really wasn't the patient pain issue. It was popularized, and it really wasn't, the more rapid mobilization. And I think they are surviving the critical test of time and data, and those effects are real. But what I liked was the fact that Dan and I can get an X-ray every single step of the operation. With a posterior approach, you can't completely control pelvic rotation. I don't have a lot of patients in that age group with BMIs less than 25. I just don't. I've got a lot more in the 35s, and so it's hard to really know what your rotation is intraoperatively, and you do your best to see through small incisions. And in the old days, we got an X-ray and recovery room, and it was what it was. And if it was egregiously bad, you would have to rethink and maybe consider doing something, but only in that situation. Nowadays, we'll have taken X-rays every single step of the way. We'll know exactly what we've got, and the joke is, do you want an X-ray and recovery? And you kind of look and go, really? We know exactly what we have. And so, in my mind, I think my concern with any new technique is forget the short term, let's look long term. Because it's really about, do we have more happy patients at age 20 years out, 30 years out? And I think in my case, I can do it more reproducibly and more accurately with those X-rays every step of the way. So the long term, who wins the race, the turtle or the hare? I think this is going to, stand the test of time. I think we can more consistently do a very good hip. So that's my one little caveat there.
That brings up, Sean talked about BMIs. That's the other thing that I've found with an anterior approach. I don't know if you have, Sean, but it's a whole lot easier to do an anterior approach on large people. I've done them with BMIs up to 38, 40, and it's not that much more difficult.
So the quick caveat I want to close on is send your skinny patients to me and your heavy ones to me. I couldn't help it. Sorry.